Hey everyone, thanks for joining me on another video. Thanks for all the support and taking the time to watch the videos. It really means a lot, and I hope you guys get a little bit out of it. Let me know if you want to hear about other topics or if you have any other suggestions. So today we're going to be this is a follow-up to the video I just posted on kind of basic ventilator physiology, and today we'll talk about some basic ventilator modes. And it's not super comprehensive, but if you find yourself in the ICU, it might just give you a little bit of an inkling about what's going on, so that if people ask you questions, you'll look like you know what's going on. All right, so without further ado, let's get cracking. Alright, so starting with the first mode we're going to be talking about is going to be assist control, volume control. And the first four that we have here on the screen, the most important thing, or I should say one of the most important things we talk about, is setting the rate. So with all of these modes, we're going to start by setting the rate. Now the other thing with volume control, as it suggests, is we want to set the volume. So I'm going to say the tidal volume here is abbreviated to VT. So we set the respiratory rate and we set the tidal volume in addition to things like the FiO2. Now, what this is going to look like in terms of delivering a breath to a patient. So if we set the rate at, let's say 10, we set the tidal volume at, let's say 500. Well, each breath it's going to give a volume of 500 mils, and it's going to give these breaths in accordance to the respiratory rate. So this is, let's say, 10 breaths per minute. If I've drawn it correctly, it should be roughly equal. So it's going to give 500 breaths. Now, one of the downsides is that a patient can take their own breath. So in between some of these, the patient might, try and breathe a little bit. And that is going to, if left unchecked, patients can obviously keep breathing and increase their minute ventilation and drive off their CO2, and that can cause a respiratory alkalosis. Just have a note here that there is no pressure support, and we'll come back to pressure support in a second, but remember that pressure support is that driving inspiratory pressure of air, so the patient, that there is no pressure support in this mode. Okay, now moving on to the second mode, and that's pressure regulated volume control. Now, again, we're going to set the respiratory rate, we're going to set the tidal volume or the target volume, and the FiO2. And we can use the same kind of settings we used before, which is 500 for the tidal volume, 10, and the FiO2. Doesn't matter in this scenario. Now, what it's going to do is this is slightly, it looks a bit similar to the volume control. However, it's going to try and give a breath with the least pressure possible. And so what that might look like is that the ventilator might give only 480 mils. Might only give a breath of 480 mils, but the pressure that it's giving it at might be at 20 centimeters of water. And over the next few breaths, that pressure might have to go up, it might have to go down to try and get back to or roughly around the 500 mark. And what it might find, and this might be 24, and this might be 22, and it might find that this 22 centimeters of water is the lowest pressure to deliver that 500 mils. And this is important because the patient's compliance, the lung compliance is changing, the respiratory mechanics that we discussed before is going to be changing and hopefully improving. And this ventilator mode will help to optimize, or I should put that somewhere else, and this will be to, and this is to optimize the pressure support. And we can start to see, like I said, if patients are starting to require higher and higher pressures to ventilate, or conversely, lower pressures, which may signify that the patient's condition is improving. Last thing to mention with the PRVC mode is that if the pressures get too high, let's say that we wanted the pressures to be no more than 20 centimeters of water, then on this breath, what would have actually happened is that at 20 centimeters of water, the ventilator cuts that kind of tidal volume off and brings the breath back, and then that purple area might be slightly lower. It might be close to, let's just call that 400 mils. And so you can see if the pressures are too high, then what actually can happen is a respiratory acidosis, where the patient is not ventilating enough. So it provides that kind of backstop to make sure that patients are not having inspiratory pressures that are too high. Okay, and we'll move now on to pressure control ventilation. And in the first two modes, we talked about setting the volume and monitoring the pressures. But in pressure control, it's going to be the opposite. It's going to be the opposite, where we set the pressures and we monitor the volume, or the volumes can change. So we're going to be setting the rest rate again. Then we're going to be setting the pressure support, or the inspiratory pressure, and also the PEEP, which is this base, which remember is that baseline pressure that is always happening. So in this scenario, let's just call the respiratory rate again of 10. We might give a pressure support of 20 and PEEP might be 5. And so the ventilator is going to deliver a breath, and the baseline here will be 5. It's going to deliver a breath, and it's going to cut out at 25 centimeters of water, which is 20 plus 25. And then this is 5 centimeters here. And this volume might be, let's just call that 425 mils, the tidal volume. That's the tidal volume. And each breath might change depending on the patient's disposition, depending on what is happening in their lungs. So you might see progressively over the course of the day, the tidal volume might increase. Oh, let's try that one again. And it might decrease. It might go down. And that is all going to depend on what is happening inside the patient's lungs, on the fluid status, and the compliance. We can also, in this mode, change the inspiratory time. So that is kind of this, how long it takes to actually deliver inspiratory time. We can actually change how long it takes to deliver the breath, which we will talk about in due time. So just remember that pressure control ventilation is most important for setting the pressures, and we will see the result in the volumes changing a little bit, whereas in the first two we talked about setting the volume, and then the pressures were a little bit variable. And the reason I talked more about PRVC was that it's a more common ventilator mode. Now we'll move on to the next one, and that is going to be SIMV, which is Synchronized Intermittent Mandatory Ventilation. And what we are going to set is, it works a little bit like volume control. So we're going to set the rest rate again. We're going to set the volume. And of course, we're going to set the FiO2. Now, again, we'll stick to 10, we'll stick to 500. And what is going to happen is that the ventilator is going to provide breaths very much like volume control at 500 mils, and it's going to deliver a rest rate of 10. But what's going to happen is that the patient can trigger their own breath, and generally SIMV is given to patients or as a mode where the patients are not fully sedated. Otherwise, if they are fully sedated, it is essentially volume control. So this is a patient who's not sedated. And what happens is that they might trigger their breath here, and basically the patient breathes for themselves. They determine the volumes they breathe. So they might only breathe 200 mils. And what they breathe is what they can do is what they can get, is what they get. And that is the difference between SIMV and volume control. Now, if they were to trigger a breath near the respirate, which is exactly what I've drawn here, so if they were to trigger a breath here near the respirate, what will actually happen is that they get the 500. The ventilator gives them the 500. But if they were to trigger a breath, let's say here, before that 10 were to occur, that respirate of 10, then they'll get whatever they can do. That's the 200 there. So basically, we give them a minimum ventilation, but the patient can breathe on top of it. And this allows them to develop spontaneous breathing. And just important to note there that if patients trigger their breath near the respirate or on the respirate, the ventilator will deliver the full breath. So I'll just make that clear, is that the ventilator delivers the full breath. But if they do it slightly afterwards or slightly before, then what they can do is what they get. And if they are not breathing by themselves, then this mode is essentially volume control. All right, and we'll talk about one more mode just now, and that is pressure support. And it is different. And it is different to the modes we talked about above, because instead of setting things like the respiratory rate, the pressure, or the volume, we only set two things, and that is the pressure support and the PEEP. And some of you might recognize this pressure support as what we give to patients when we give non-invasive ventilation. So this is pressure control, and it's different because this is a ventilator. It's more descriptive of what we're giving. And this is more, we're letting the patient breathe for themselves. We're just helping them with a little bit of PEEP and a bit of pressure support. So this is a spontaneous mode. Spontaneous. And this is a ventilator or a prescriptive respiratory rate. So for pressure support, we might give them, much like before, let's just say we give them 20 and a PEEP of 5, and then the breaths are going to look like this. They're going to look much like this, much like before, very similar in fact to pressure control, and this might be 425, except the patient is going to breathe for themselves. This might be 400, and they might start to get a bit better, start increasing their tidal volumes, like so. And essentially this is kind of what might happen if you're giving someone non-invasive ventilation. So non-invasive ventilation, or in the operating theatre as you're preparing to extubate, you want to make sure that they're able to take their own breaths. You might start with SIMV to make sure that they are taking spontaneous breaths, and then you might progress to pressure support, and that's pretty much all there is to it. And yeah, like before, lung pathology and particularly compliance will affect these numbers, so you will see them vary and go up and down. If the patient is extremely tachypnic and is really breathing fast and maintaining good tidal volumes, then yes, you'll develop a respiratory alkalosis, and conversely, if they're hypoventilating, then they will continue having a respiratory acidosis. But generally what you're doing, if this is a non-invasive ventilation trial, then you're just seeing whether you will find some improvement with these settings and all the respiratory and cardiovascular effects they give to patients, like we discussed in our first video, before maybe progressing to actual invasive ventilation if that's the case, if that's necessary. So yeah, today we talked about 5 different ventilator modes, and we talked about them in a little bit of basic detail, but volume control, pressure regulated volume control, pressure control, and SIMV are where we set the respiratory rate, and pressure support or non-invasive ventilation is really when we have spontaneous, that's a spontaneous mode. We talked about how pressure regulated volume control delivers the lowest possible pressure when you prescribe a tidal volume, whereas pressure control, the tidal volume will vary given the pressures that we set. And SIMV is a little bit unique when a patient can breathe for themselves and they will get whatever spontaneous breath that they choose to breathe. However, there is always a backup rate that the ventilator provides just to make sure that the patient isn't hypoventilating. So that concludes our basic ventilator physiology and modes review. I hope you guys really enjoyed it. Please let me know what you guys liked, what you didn't like, what you found useful, and maybe what you would like to learn in the future. Thanks for watching, and good luck with studying. Thanks for watching. Bye.